Part of our philosophy here at San Antonio Orthopedic Specialists is that we take care of whole people, not just imaging studies and not just bad hips or bad knees or bad shoulders. And so I'd like to talk a little bit about why this is and give some examples about how the problem may not be what matches the imaging. One example that I use very frequently in the office is that I've replaced many hips in people who first came to me for knee pain. Because where the problem is and where the pain is don't always match. And part of our job as physicians is determining where the problem is, because if you address what you might find where the pain is, you don't always fix the problem. At the same time, there's not always a perfect match between imaging and symptoms. I have up here on the screen an example. The right hip, which is this one over here, has been replaced. The left hip, you can see, is bone on bone. There's no space between the ball of the femur and the socket in the pelvis. So this is an end-stage arthritic hip. This patient, though, has no pain from that hip, has no limitations from that hip, and so therefore gets no surgery for that hip. Now, the odds are at some point it's going to hurt, but that's when you address it. You don't treat the x-ray because you can't see pain on an x-ray. You can't see disability on an x-ray. You can't see physical impairment on an x-ray. You can only see the arthritis. This example is a knee replacement patient. The left knee, which is this one over here, has been replaced. That one's doing very well. The right knee over here, again, has bone on the inside portion of the knee. The outside portion of the knee still has a lot of cartilage left, but there should be a space on this side of the knee similar to the space that's on that side of the knee, and there just isn't. At the same time, he has no limitations. He can walk as far as he wants. He has an occasional minor ache and pain, which is covered by Tylenol or an over-the-counter medication such as aleve. So if someone is taking, say, 1 aleve or 2 aleve a month, is that a reason to operate? No. I don't treat the x-ray. We treat the patient. It's the orthopedic surgeon's job to help balance what you find on the imaging with what the patient's problems might be. A common problem with a knee MRI, for example, is that the first item listed will be a macerated, torn, or displaced meniscal tear. That's a problem. The second item, though, is stage 4 or end-stage Kandra Malaysia, which is another fancy term for end-stage arthritis. And so if you have end-stage arthritis, that's the elephant. The meniscal tear is the mouse. So if you treat only the mouse, you leave the elephant and the patient's not going to be much better. But sometimes people will say, well, can't you treat the meniscal tear with an arthroscope? Yeah, you can. Not going to fix the problem, though. So you have to try to match what you find on the imaging study to what you find on the exam of the patient. Between 60 and 80% of patients who have no problem with their hip, and they are 30 to 50 years old, will have MRI evidence of a tear in the labrum. So it would be inappropriate to treat all of these torn labrums because you're operating then when you have no symptoms. On the other hand, not all hip pain is a torn labrum. And so that you have to find why an individual patient has hip pain. And if it's the labrum, fine, treat that. If it's arthritis, treat that. If the problem is really the back, well, treat that. You have to make the treatment match the patient. The imaging helps, and when the imaging and the symptoms and findings match, then you have the proper diagnosis, and then you can go to the proper treatment.